following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. This series is supported by independent educational grants from Astellas, AstraZeneca, Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, Lantheus Medical Imaging, Merck & Co., Inc., Pfizer, Inc., and Sanofi Genzyme.
Good evening. My name is Jay Raman, and I'm Professor of Urology at Penn State Health and Chair of the AUA's Office of Education. It's my pleasure to host another one of our episodes in the AUA Expert Exchange podcast series, Discussions in Genitourinary Cancer. Today's show title specifically is Advanced Kidney Cancer, A Guide to Targeted Agents and Immunotherapies. And joining me today are two real thought leaders in the field, Dr. Monika Joshi and Dr. Brian Shuch. Dr. Joshi is an associate professor of medical oncology at the Penn State Cancer Institute in Hershey, Pennsylvania, and she's the medical director for the clinical trials, and her research interest is in clinical trial development for urologic malignancies. Dr. Brian Shuch is associate professor of urology at UCLA. He's the director of the kidney cancer program and the Alvin and Carey Mind Heart Endowed Chair in Kidney Cancer Research. He's an accomplished surgeon through a variety of different techniques and has done an enormous amount with clinical and translational research, particularly with kidney cancer. So first of all, Monika and Brian, thank you so much again for joining. It's really our pleasure to be able to have you and sort of pick your brain for the next 30 minutes.
Thank you. Thank you, Jay, for inviting us, and we look forward to our discussion.
So for today's episode, we have a few learning objectives. One is to discuss current targeted and immunotherapy options for the treatment of kidney cancer. Talk about some of the completed and accruing trials that are defining sort of the paradigms of use for immunotherapy in this disease state. Best practices for patient selection, as well as treatment options, as well as talking about treatment plans, sequencing of therapy, and recognition and management of adverse events. So maybe I'll sort of kick it off with both of you and sort of have you maybe bring us up to speed as listeners on where we are with regards to initial management of kidney cancer. And I guess, what I would say first and foremost is, obviously when I was certainly going through training and whatnot, the paradigm was nephrectomy up front. So somebody had metastatic kidney cancer, it was nephrectomy up front, and then thereafter management with any systemic therapies. Maybe first, I don't know, maybe I'll start with Brian. Talk to us a little bit about, what was sort of the data? Why did we practice that way? And then maybe I'll turn to Monika on, what is some of the newer data that's out there that perhaps is causing us to maybe change our approach or at least modify our approach?
Great, Jay. So I will tell you that historically, the primary tumor never responded to really systemic therapy in the interferon and IL-2 era. So it was setting the paradigm for patients to have their tumor debulked. There'd be about 2 to 3% of patients would have a systemic regression. You would also improve their symptoms. And there were 2 randomized trials showing a survival benefit with debulking up front. So for about 20 years in the modern era, after 2001, the Flanagan paper, there's a McKish paper, we kind of set a tone that most patients should have upfront nephrectomy. However, there were patients who did very poorly with that approach when they would have rapid progression and they wouldn't get systemic therapy.
And Brian, just ballpark wise, when we look at some of the older data, just give the listeners a sense of, what was that survival benefit that we were seeing when you looked at sort of upfront debulking of the primary tumor?
So again, it depends on the patients that are selected for, but in those trials, we were talking about the patients who did not have surgery had about a 7 to 8 month median overall survival. and those who had surgery had about a 13 to 14 month. And it's important to put that in context because you'll see some of our newer trials actually have similar outcomes because they're probably much sicker patients than included in that trial.
So, Monika, maybe talk to us a little bit about the Carmina trial, perhaps, and maybe how that has really resulted in us maybe rethinking a little bit about how to manage metastatic kidney cancer patients right out of the gate.
Yeah, thank you for that question. So it's really a very challenging era. So when these trials, what Brian talked about, the SWOG or the EORTC studies, they were done way back in the era of interferon, and now when we reach the targeted era, I think that's when Carmina was designed. So Carmina was designed to see a non-inferiority if we do an upfront nephrectomy followed by the TKI versus Sutent upfront. And it was 450 patients, and they randomized them. And unfortunately, it did not show the similar benefit for XYZ reasons, but the overall survival was about 18.4 months in Sutent and about 13 and a half or close to 14 months in those who got nephrectomy. So it was considered non-inferior. It's important to note that I think 38 patients in the experiment, in the standard of care, like upfront Sutent, did get nephrectomy. So that was one of the first prospective phase 3 studies in the era of TKI that suggested that upfront nephrectomy perhaps is not favorable. It didn't really answer the question about delayed nephrectomy. That's what the Surtime study was looking into. And unfortunately, it didn't accrue well, but it did show that perhaps delayed nephrectomy could be option. And that's something that could be studied. Here we are. But now the era of TKI has changed to immunotherapy. Right. So we're not still clear as what to do. But as a standard of care, currently, I think treatment is advised unless we super select these patients.
Sure. And Brian, maybe your thoughts on one of the points that Monika made, which is, sure, the landscape is changing, TKIs, and we're going to talk a little bit about immunotherapies. But maybe give us a sense in your practice and the practice at UCLA. Are you doing, for those patients that perhaps are responders to systemic therapy, are you doing delayed nephrectomies? Are you sort of doing consolidative surgery on the primary? How often is that actually occurring?
So I will say the era of upfront surgery is not dead for patients who have bad symptoms. It's a great palliative approach, and some patients are going to get into trouble while they're on systemic therapy. And we also have a lot of patients with very small volume disease, which you would consider watching, and those are great patients for upfront cytoreductive nephrectomy. I would say maybe that's about 10 to 20% of our patients. Now, we do a lot of consolidative nephrectomies here because we have a lot of patients who've had very good deep systemic responses. We have a lot of patients where when good 60 to 80% or more of the disease is in the primary, after about 4 to 8 month range, we have gone and picked off the primary tumor. It's usually in the era of now we if we have oligometastatic disease, we also try to pick off the metastasis too with like ablation or SBRT. So we are doing it. I would say that we haven't seen many complete responses in the primary tumor pathologically. Again, the PROBE trial, which is led by Ulka Veshkampayan and Young Kim through SWOG, I think will hopefully answer that question. But there are only about 90 patients in on about 300 or 400 patient trial so far.
So let's spend a little bit of time talking about upfront systemic therapy for metastatic kidney cancer. And maybe we'll start off with clear cell histology, because I think, proportionally that's going to be the majority of the patients that we end up seeing in clinical practice. Maybe either Monika or Brian. So where are we with regards to systemic therapy? Monika, you alluded to the fact that obviously, we've evolved very much from the TKI based therapies. Talk about, where we've evolved to, and also the concept of, single agent versus combination therapies.
So in the present era, I think people are looking into the researchers. What we have established is definitely for kidney cancer, the world is moving towards doublet. So getting the best of both sides, the TKIs as well as the immunotherapy. In particular, when we talk about immunotherapy, the checkpoint inhibitors. So several of these are already approved based on the phase 3 data. So we have axitinib and pembro that got FDA approval in 2019. And it clearly showed a response rate of about 59%. It was compared to Sutent, which was 36%. And similarly, since then, we've had Ipi and Nivo that had gotten approval as well in this. And then we have cabozantinib and nivolumab that was, I think, approved back in January of last year. And then we have the clear study data, that's the Lenvima and pembrolizumab. And those two combinations, actually, particularly the Lenvima and pembro combination, as reported, is showing really response rate around 71% and clear survival benefit. So apart from the double immunotherapy, this ipilimumab and nivolumab that had shown about 42% or response rates, all of them are like above 50%. The Ipi and Nivo combination is currently recommended or used mostly for intermediate and poor risk, whereas all of these can be used for all three risks, good, intermediate, and poor. We also had the recent data reported from the COSMIC study. That was the triplet study for Nivo, Ipi, and Cabo. I think, the benefit comes with the price, actually, that you have more side effects. So more and more trials that are trying to do, we have, even Pedigree, one of the trials led by us, Tian Zhang's group, and what they are planning to do is to do a doublet upfront and then define the sequence. So at this present time, I think the world, if a patient comes to us, we do evaluate. Is single agent dead? I don't think so. There are some patients who would benefit, so it's not clearly gone off, or who may not be a suitable candidate. So yes, so doublet is the option at present.
And Brian, maybe to sort of dovetail on this. So clearly, Monika has highlighted that combination therapy is increasingly moved, to the forefront of how these patients are treated up front. And one of the points that she made, and maybe just educate our listeners, is a little bit on risk, right? Assigning risk and the different risk strata. Just broadly, can you just explain to our listeners the concept of risk when looking at metastatic kidney cancer and how that risk may impact your decision making, the different risk groups, with what, and maybe some of the different criterion that are out there for assigning risk?
Yeah, so I will tell you that in prior eras, obviously there was a wide range of outcomes. I think a lot of our patients today are doing better than ever. The median survival today for a new diagnosis of metastatic kidney cancer is almost 4 years, which is remarkable. But in trying to define risk, the initial series from Motzer and colleagues at Sloan Kettering had a criteria of, it's called the Motzer criteria. And then later this was updated to another one in the more modern targeted therapy era called the IMDC. And they look at things looking at, time to treatment, greater or less than a year, Karnofsky performance status of 80 or greater, LDH, calcium, hemoglobin. In the IMDC, we're also looking at things like neutrophils and platelets. But basically, if you have no prognostic high risk, you're considered a low risk group. Pretty much anyone with a new diagnosis is probably going to get treated. So pretty much all new diagnosis of kidney cancer, you're going to at least have that time to treatment of less than a year. So they're automatically in that intermediate group, which is going to be 1 or 2 prognostic factors. And then the poor risk group are really going to be 3 or more. I would say that in the current era, where you have such good outcomes with immunotherapy, we're really not sure how these will perform. Will they perform as well? It's kind of unclear. But as Monika said, we have so many different options in the first line. Pretty much NCCN includes, all these as options. The only thing which is not included for the favorable risk group is really that ipi-nivo. That doesn't mean patients will do well with that. The trial was focused on the intermediate and poor risk group. There was a small subset of patients with good risk or favorable risk, and the small patient cohort did favor Sutent, and that's potentially because they're more VEGF driven. But there's really no biomarkers to determine who's going to do best. But we try to, again, risk stratify patients in that intermediate or poor or favorable risk, which may be a little less relevant now in this era because patients do, sometimes well regardless.
Sure. So I guess, the very practical question I would ask you both is, Monika highlighted, and you mentioned as well, Brian, that if you look at the NCCN guidelines, there's a number of different options that are available, right? So there's a number of different combination therapies, that all of which would be reasonable options in the first line setting. So is this a little bit dependent on individual institutions and practice patterns with regards to which combination that we use? I mean, how does this sort of practically play out in practices?
Yeah, I mean, I would tell you, you break patients down, the treatments down into IO or IO TKI. The median time to response does look a little quicker with a VEGF TKI. It's not that the IO combination therapy is going to take like a year or two. I mean, the median time to response is 3 to 4 months, but in the trials with the TKI, the median time to response is about 1.8 or 2 months, depending on the series. So if you have a patient who's really sick who needs to have a response, a lot of people favor a TKI-based regimen.
Yeah, I would second what Brian said. I think when they come to our practice, you have to determine whether they will even have enough time to evaluate the response, right? So don't forget the pseudo progression that we talk about. So we have to have a confirmatory scan. So if somebody comes with poor risk features, or you want to give them the benefit of both worlds, the TKI as well as the immunotherapy. But it's also important to note that the best benefit for the immunotherapy doublet is actually in the upfront setting, because there are various other trials that have been done in second line or third line, and we don't see so much of CRs in there, whereas the complete responders reported in the initial studies about 10 to 11%. So I think that gives you that advantage. But at this time, we don't know, other than knowing these are the therapies, and most people would lean towards TKI and IO. We don't know which TKI and IO is better because it hasn't been compared. So I think it's whatever people are comfortable with and can manage the toxicities. I think that's what you should choose.
Yeah, I would say that comparing across trials is very challenging. You say, oh, look at the CLEAR trial, there's a 71% response rate, but there's a clear difference in who's included on these trials, differences in the intermediate or poor or favorable risk group. So it's really hard. I'd say that a lot of people just find the regimen they're comfortable with. Again, a lot of times for some drugs, they need to be dose reduced. So I'd say a lot of my colleagues just find the regimen they feel comfortable with and then go with it.
And I would also add to that, if there is a clinical trial that's going on evaluating, I would definitely encourage the listeners and the physicians to discuss with the patients, because it adds an extra layer to what the standard of care is available. So if the patient is fit for the trial, then definitely discuss that with them.
And then the triplets, obviously there's triplets in trials, and then the triplet, that was just shown to have improvement, ipi-nivo cabo versus ipi-nivo. I would say that, everyone expected there to be improvement in this progression-free survival, but I think a lot of people were disappointed that there wasn't like a much higher rate of a complete response. If patients are going to have much more toxicity, you want it to be for something more than just an extra month or two of delayed progression. You want to see increasing, maybe complete responses. So that the overall survival data in that trial are going to obviously take a long time. It's very intimidating to do a first-line trial now, because it might take 5, 6, 7 years to see a difference.
So what about duration? How long do you treat? So let's say you have a patient who has a very good response on therapy. What is the endpoint? When do you stop? When do you give them a challenge off of therapy? I mean, maybe there's no good answer to this, but what do you do with these patients who've had a great response? And obviously, we're going to talk in a minute about toxicities, but all of these therapies have some inherent toxicities. But what's sort of your thought process on duration of treatment for these patients?
So, I mean, that's an excellent question. I think currently, if you look at most of the trials, I think they at least treated for 2 years. But the jury is out. We do not know how long to treat. I know what I do in my current practices, and I have few patients who did so well that I ended up stopping the treatment and said, "Let's watch." I even, I think we opted for one of the patients I recall had excellent response, and there was this lesion left, and we opted for the primary to be removed. There was no cancer found. So I think those who respond, who have complete responses, they do really well if you stop. Those who have partial responses or stable disease, I would not recommend to stop. And sometimes you can tailor down the treatment. So if it's an IO and a TKI combination, then you could use, if they're having one toxicity versus the other, you could continue one and stop the other. But yes, I think a lot of others, other oncologists around the country would also perhaps consider stopping in those with complete responders after a certain duration of time.
So I think I think we've learned clearly this is different than the TKI era. So in the TKI era, there's one particular paper from Laurent Salvagez where they stopped Sutent, even the patients who had CRs, and over 50% of them ended up having recurrences. We don't know if this is going to be like IL-2, where we have patients who are alive 15, 20 years later who've had a complete response. I'll just say that our colleagues, a lot of colleagues in the oncology field are historically melanoma and renal docs. I'd say this is probably not as the CRs might in talking to the people, like the Mike Atkins, the Mario Snowles who treat melanoma. They've been treating with these agents for a lot longer than in the kidney cancer GU space. They do see that maybe the CRs are maybe a little less durable in the melanomas, but there are patients who are able to stop therapy, and only time will tell if they're really long-term remission.
So I think Monika alluded to this a little bit earlier, but let's talk a little bit about toxicities of therapy and toxicities of treatment. And, I think this is important because I would say, in our practice, for example, our urology group doesn't really give any of these therapies, but we certainly share a lot of patients. So I feel like what you might end up seeing in clinical practice is common patients who may have some AEs, and therefore when they call into the hospital or they reach somebody, these might be the conversations that occur. So maybe let's start first with maybe the checkpoint inhibitors and immunotherapy. What are some of the common AEs and side effects that patients experience, and how do we manage them? And then we'll talk about maybe the TKIs.
Yeah, so the checkpoint inhibitors, because it's boosting your immunity, right? So to fight against the cancer. And the body itself has the balance between your immunity. So some of these, autoimmune like symptoms could occur because the suppression is needed. But when we give checkpoint inhibitors, I say majority of these patients, the good news is they can tolerate it well. They can have a healthy quality of life and continue doing what they are. Fatigue is one of the common symptoms that patients would report. If you go system-wise, I think these patients can really have adverse events or side effects related to any of the systems. So they can develop rash, diarrhea, like the immune-related colitis. They can have arthritis. Those are sort of the most common hepatitis, autoimmune hepatitis, or what we say immune-related nephritis can occur. Effect on the nervous system is less than 1%. Effect on any other cardiology or myocarditis type is less than 1%. And we also see a lot, I think I see a lot of patients probably who have hormonal imbalance, like thyroid disorders, or mostly hypothyroidism than the hyper. And we also see adrenal insufficiency. A lot of these things could be kind of managed carefully. So educating these patients when you start the treatment, telling them what to do, how to report it, informing their treating physicians early on so they can help them manage. And this is where I think the clinical trial data kind of helps us understand. So if we have to, as physicians, like grade something, so how severe the problem is, it's the grade 1 to grade 4. And if it's grade 1, most of the things are managed very easily with conservative. Say, for example, you have a rash, just applying like triamcinolone or a steroid cream could help. Or if, or diarrhea like Imodium, those things could help. And guiding the patients to tell us hydration, drinking plenty of fluids could help prevent increase in creatinine. Watching out these urine protein, like if it's high, you can pick it up, start them with ACE inhibitor or ARB inhibitor, ARBs that could help decrease your urine proteinuria. And picking these thyroid disorders early on, you can actually supplement them so patients don't even notice these side effects. Now, the problem comes in when they develop like grade 2 or a grade 3 effect. And that's when I think the recommendation is to hold and treat them with steroids, because we're increasing the immunity and steroids are the perfect partner to decrease. So you can treat these patients with oral steroids, let the toxicity come down to like mild or grade 1. And then a lot of us would re-challenge them. Now, it depends how soon the toxicity occurs and what is affecting. Like, I mean, you will probably be more eager to start somebody a re-challenge if they come down with their rash rather than like if they have a cardiac associated because of the immunotherapy, you'll be less than eager to challenge them. For diarrhea, it's a little bit different. You can start with steroids and let symptoms calm down and you can re-challenge. The ipilimumab or the CTLA-4 is much more nastier. So I think none of us, at least I would not restart them on CTLA-4 if they have a grade 2 colitis. There are other medications like infliximab or vedolizumab that can be given if patients become steroid refractory. So yes, it's like art of medicine. You see
Right.
patients and treat them.
Brian, what about the TK inhibitors?
Yeah.
What will we be seeing? What will patients talk to us about? And how do we sort of manage the side effects of the TKIs?
So I'm going to make a pitch to have us have the listeners look at our AUA update series, where there's a great pictorial. This is from last year. It's about kidney cancer, the nuts and bolts of systemic therapies, and they have a great pictorial view of each organ system and each TKI versus PD-1 versus mTOR. I will say that, again, we're not really giving, monotherapy TKIs, but if you were to pull out the TKI monotherapy, again, 50 to 70% of patients are going to have some fatigue. Hypothyroidism is also very common. People with some of the older ones like sorafenib, there's a much higher incidence of hand-foot syndrome, which is more PDGF driven, but it's fortunately a little bit less with the more cleaner agents. But diarrhea can also be common. A lot of patients also have a dysphonia. Their voice changes when they're on therapy. And then, it's not uncommon to have things like diarrhea. Some patients, with Cabo and pazopanib, they can get some hepatotoxicity. But hypertension is also an on-target effect. It's actually something which, is actually sometimes a good biomarker. Brian Rini used to say with axitinib, sometimes you would actually titrate up to make sure you actually got, hypertension. It's a good biomarker that you're hitting the VEGF target. But again, a lot of these, monotherapy TKI is not really, given, and it's just usually given in combination, unless maybe the patient had a bad side effect from the PD-1 and you really weren't comfortable giving it.
So we talked a little bit ago about first-line therapy. So let's maybe now move to the second-line setting. So maybe I'd start with you, Brian. When I say second-line setting, what does that mean? I mean, how do you define somebody that needs to pivot from first-line therapy to second-line therapy? And maybe then for both of you, what are sort of the second-line options that are available?
Yeah, so I mean, second line therapy means basically your first line of treatment has failed. your patient is progressing, or they couldn't tolerate the first initial choice of systemic therapy, and they need to try a new regimen. I would say most patients are able to get on a second line therapy, but there are some patients who just get, one treatment and then they can't, get additional therapy. In other countries, that's, I think, more common. I think there's much more supportive care here. So, sometimes you want to shoot all your guns up front, but I think in the US, we have, consider this second line more salvage, and most patients are able to get it. The landscape is changing so much because all of our trials that we're looking at second line therapy, the cabozantinib, we had patients who were getting, axitinib. These were agents that were tested really in the second line therapy. How relevant is it when patients have received the PD-1 inhibitor? When in that era, when we were testing some of these drugs, they didn't have those agents available. But the landscape is rapidly changing because there's a whole host of other trials that are going to be coming forward. But we consider these agents like cabozantinib, lenvatinib, everolimus. Nivolumab actually was first approved in the second line, after failure of TKI. But again, the landscape has completely changed since a lot of these initial trials led to the approval in the second line space.
So, sorry. I would agree with what Brian said. I think there's so many options that if a patient tries, and it's unfair to have so many options in first line. So a lot of us would try whatever you didn't try in the first line as a next line. But it also depends upon what the patient is like. If they have an IO and a TKI, they have sort of a good response in some areas and not so good response of progression. Then could you consider changing to a different IO and TKI combination? Or if they have like a really intolerance to immunotherapy or something, you can consider a second line. Or if they have a TKI issue, could you consider just going to single agent nivolumab? As Brian pointed, I think it has a 25% overall response rate in second line. So another agent that's on the horizon for the TKIs is the tivozanib. So, that was recently approved. That's also a good option. It has a better tolerability, and it was really approved for like third line. So patients were quite beaten up and treated. But there are single agent TKIs like, still you have your Votrient alive, you have your cabozantinib, lenvatinib, and everolimus. So, and anything you didn't try. So Lenvima and Pembro also have some data in second line setting that could be used. And same for Cabo-Nivo or Nivo too. Although for the latter, I as I pointed out before, I think the best use of an IO doublet is in upfront setting, and in the salvage setting, it's not as effective.
So I would say that it is generally agreed upon. If you had Cabo-Nivo, you were not going to use Cabo in the second line. If you had Len-Pembro in the first line, you're not going to use Len-Everolimus in the second line. So again, you'd mix it up. I'd also say that a lot of people who have what we call oligoprogression, where they have maybe a couple lesions that are growing, this is a great time to consider, can you actually pick off a couple of those lesions and then continue the therapy? Mm-hmm. Because again, you don't want to burn all your, all your drugs. And if you can get more out of it for another maybe 6 months, a year, you might be able to treat that one or two, growing lesions with a local treatment option.
And then I think just other thing to point out what Brian said is if you have an oligoprogression and that area is not accessible, if it's for surgery and for most of the patients, opting for a radiation and SBRT approach, because that the radiation also has some synergy with the IO. So whether that could improve the response or maintain the patient on the same drug before changing it to next line, because you don't want to exhaust your options.
So in terms of exhausting options, I would say that that's one of the reasons why we like to use our Nivo-Ipi at UCLA, because ipilimumab in the second line setting, there's been a Hoosier oncology trial, there's other types of trials where a lot of patients after they receive Nivo, they're not able to get ipilimumab once they progress, and the response rate is not so great. So it seems to be better given up front.
So, and then in the last sort of 5 or 7 minutes or so, I'm gonna sort of pick your brains on maybe a few different topic areas. So the first one is hereditary kidney cancer and the role of genetic testing. So maybe just educate our audience on what are the indications for genetic testing, and what is the percentage of time perhaps that we identify a genetic mutation, and how does that impact our treatment options?
So I will tell you that there's very poor consensus amongst the different, panels, committees. We're fortunate that, the NCCN does have a new, at least 2-page listing of recommendations. But Dr. Bratlovsky, my good friend from Syracuse, we did lead a consensus conference, 2 years ago or 3 years ago. It's in cancer. And then we had an updated one where we had medical oncology, urology. I would say that a lot of the things are controversial, like age of onset, at a certain age, but there was pretty good agreement. Multifocality, family history, if you have first degree relative, if you have 2 or more second degree relatives, if you have suspicious histology like an FH deficient or an SDH deficient tumor, a hybrid oncocytic tumor, those are ones that should receive further germline testing.
Yeah, I would agree with what Brian said. I think NCCN puts a very nice, guideline. I think genetic testing has become important in this era because we're doing more and more tumor genomics. So we don't want to kind of miss on picking up these, because as the treatment platform is changing, like especially with the VHL drug coming up, or other abnormalities that are being picked. So as patients are having these tumor NGS, sometimes they don't tell what's genetic, but you can get some idea about what could be. But yes, I think patients who have multifocal tumors, or especially if they have first or second degree relatives with the RCC, or anybody in the family with any kind of a genetic abnormality, I think those are high on the list to be tested. And again, the histological appearance should also point towards that.
We're not at the test everyone approach like pancreatic cancer, but that clearly there's therapeutic options with PARP inhibition, or test a large number of patients. So we're kind of selective now, because really, other than maybe the implications for family members, or for maybe HLRCC and now VHL localized disease, we really don't have it affect treatment.
So I think you both mentioned a little bit, but talk to us a little bit about belzutifan and sort of how that's used for VHL related kidney cancers. What's the clinical scenario, and what's sort of some of the data underlying this new therapy?
So belzutifan is the HIF-2 alpha inhibitor, the approval has come for the VHL associated RCC, especially when not candidates for surgery. And in the cohort of 60, I think 61 patients, they observed the overall response rate of about 49%, but more than 50% of the people had good response at year 1. So that kind of led to the approval for this drug. We haven't used it so often in our clinic. I would be frank. I mean, I'm looking for a patient whom we can give this. There are studies going into metastatic advanced RCC who have, in trial of this as well. So we'll know more about this. But I don't know, Brian, if you guys have used belzutifan.
Yeah, so I run our VHL program, and I comprehensively kind of manage a lot of these patients. We have about 100 patients at UCLA. And I will tell you that the drug is very well tolerated. I mean, it's very tolerated that, I feel very comfortable giving it. Some endocrinologists give it, some neuro-oncologists give it, medical oncologists give it. The side effect is about 10% of patients have grade 3 anemia, where they potentially have to either have dose reduction. In the trial, they were giving patients, EPO agents, but the FDA has said that's not a good idea. So we give people transfusions. But the patients also can have hypoxia. They're fortunately not very symptomatic, but it is something we have them check their pulse ox. But the indication for this is very broad. It's a patient with a CNS, which means usually brain or spine, pancreas or kidney tumor that needs treatment, but not urgently. meaning that they really haven't passed the surgical threshold. If you have a CNS lesion that's causing cord compression, clearly you need surgery. If you have a tumor that's greater than 3 centimeters on that trial in the kidney, you went for surgery. The question is, can you actually treat beyond those classic principles? It's unclear. But I have about 8 or 9 patients on therapy right now, and these are patients who've had multiple operations, and they really want to avoid future treatments. And the trial is pretty clear that a lot of these patients had surgery, and then they go on therapy, and they seem to have less need for surgery.
And final question for both of you. So we spent a lot of time talking about clear cell histology. What about these patients, which albeit are less common, but those with non-clear cell histologies? How does the treatment approach change?
So for the non-clear histology, I think, all these agents are also being tried in non-clear histology. I think one of the studies to point out is Monty Paul's study, the SWOG 1500 that used cabozantinib for these non-clear cell patients and had a response rate of, I think, 23%. So that is also a choice. You have Sutent. There are other combinational therapies like Lenvima and everolimus. We've used it's been tried in the phase 2 studies and have some promising responses, as well as the Ipi and nivolumab. The response rates are not as similar to the clear cell, but it has about 20% of response in non-clear cells. So again, these choices still remain. One caveat in the non-clear cell type is patients who have like a sarcomatoid histology or rhabdoid, they tend to respond very well to immune checkpoint inhibitor. That's emerging as one of the biomarkers, and some of the sarcomatoid cohorts have shown better responses with the IO doublet. The other thing to remember is your medullary cancer or collecting duct. I think those don't respond to your conventional TKIs and stuff. So I think something to think about: chemotherapy. I know MD Anderson has a number of trials for these patients, but they're very rare. But that's, the options are still open for non-clear cell.
Yeah, I would put a plug in for, again, cabozantinib did show superiority versus Sutent, but now there's a SWOG S2200 trial led by Ben Mon with Monty as well, which is looking at Cabo versus Cabo-Nivo. Again, we would hope that immunotherapy helps improve PFS, but we just haven't shown it. And that's what the trial is focused on. And then for HLRCC, which is probably about 5% of our patients that have papillary, if they get sequenced and are found with a germline mutation, beverlotinib is a very well-tolerated regimen. While I was at the NCI, I treated it, half the patients on that trial, the response rate is about 80%, and the PFS is about 24 months median. So, that if you do find someone has HLRCC, you open up a new therapeutic, avenue for them with the EGFR and the VEGF antibody.
Great. Well, Monika and Brian, I really want to thank you both so much. I think you're very thoughtful. I think you covered a lot of ground, touched on a lot of different things, but I think you both articulated in a really clear, cogent way. So I really want to thank you both for joining us on this AUA Office of Education podcast.
Thank you very much for having us. We love discussing this.
Great. Thanks, Jay. Take care.
And thanks to our audience. For more information, please visit us at auanet.org/university. I hope you both have a great day.
Thank you.